everyone, we are from the Ruminant Clinical Clerkship and we are very proud to present the cystic ovaries in dairy cattle. This is our members, Parima Sapon, Kavipan, Watanyathon and Saranya. This is our super cute advisors, Dr. Charlie, Dr. Ballu, Dr. Susaichai and Dr. Jikamon, Dr. Sininat and Dr. Sarawut. Our outline, we have 5 topics of it. First of all, the signalment, the history, physical examination, the POA, and the final one is the discussion. Okay, our case is a hostile fission, female Bos Taurus. She name is number 12. She is 14 years old and she was 3 out of 5 for her body condition score. And in that day, the owner said, the owner called to us to go to his farm and do the pregnancy diagnosis. Number 12, she is in the 3rd lactation cow which had been infected by the foot and mouth disease since last year, but now she recovered already. She has the days open for 6 months and the first and the second insemination was failed and the third one was conducted around the September this year. For sure, the owner called us to went there and do the pregnancy diagnosis. So the result was negative. So the third one was failed again. The physical examination in that day, she was responsive, pink mucous membrane, normal dehydration status, her heart rate and respiratory rates were normal. The CRT less than 2 seconds. Her heart sound and lung sound was normal. Ruminant contraction rate was 2 times per minute and the temperature was 1000.8 Fahrenheit. 100.8, sorry. So our problem lists are the conception failure and long days open. The conception failure can be divided into 2 systems, the reproductive system, endocrine system, and the others. The reproductive system are the ovary or the uterus, which is the cystic ovary, inflammation, infectious disease. The endocrine system can be located into 2 locations, the hypothalamus or the anterior pituitary, which is referred to the hormonal imbalance. And the others are the individual factor and the managerial factors. The individual factors such as the weakness, obesity, lactation, high milk yield, or the genetic factors. And the managerial factors are poor heat detection, insemination technique, the nutritional imbalance, and the heat stress.
Next is our initial plan. We start with rectal palpation and rectal ultrasonography. And we also perform other health checkup like we collect the blood to perform a complete blood count and blood biochemistry analysis. We also collect the feces to perform to check a parasite examination. First, our rectal palpation. When we will palpate the uterus, we found it have a normal texture, the normal firmness, and at the left ovary we found some firm texture, and on the right ovary we found a large follicle-like structure. And this is our ultrasound picture on the left ovary. You can see it's have a luteal cyst, diameter around 2.8 cm with 0.5 cm wall thickness. And this is the ultrasound on the right ovary. The enlargement that we found on the palpation is 2 cysts. The first one is a follicular cyst, diameter around 2.6 cm on the left picture, and on the right picture is another cyst, is a luteal cyst, diameter around 2.8 cm with a 0.5 wall thickness. And this next is our laboratory result of the number 12. The first one is a complete blood count. This is the electrogram of number 12. She have decreased MCHC and decrease in hemoglobin. And she also have a thrombocytopenia with decreased thalassemia. And the next one is a white blood cell. She have a little of lymphocytopenia. And she also have anisocytosis, microcyte, and we also found a blood clumping. The last one is biochemistry. She have a little bit decrease in BUN and a little bit increase in creatinine level when compared to the normal value. So this is the conclusion of our health checkup. Number 12 have a hypochromic red blood cell and thrombocytopenia, and not found but parasite. And we also found out she have a decreased BUN and not found intestinal parasite. But from this conclusion, we think that those are not directly related to the cystic ovary problem. So from our revised assessment of conception failure, the reproductive system, we can do our uterus and information from our ultrasound and our palpation. And in the outer, we can do out in the individual factor, that is a weakness, obesity, and lactation from our history taking. And in the managerial factor, we can do our insemination technique from our history taking as well. And we do in the cystic ovary because we found it in our ultrasound picture. So our tentative diagnosis of number 12 is she have a polycystic ovary.
Okay, and then let's get to know more about the cystic ovarian disease. Cystic ovarian disease is fluid-filled structures at least 20 to 25 millimeters in diameter that persist in the absence of a corpus luteum for longer than 10 days. So, it was abnormal circulating progesterone concentration interfere with hypothalamic responsiveness to estradiol, and both of these resulting in the cyst formation. And these are three major causes of the COD or cystic ovarian disease. The first one is genetic predisposition. And some reported that the genetic selection can reduce the cystic ovarian disease from 11 to 3%. And also there are positive genetic correlation between milk production and cystic ovarian disease. The incidence of the cystic ovarian disease can increase to 1.5% for every 500 kilograms increase in lactational production. The second one is postpartum abnormalities, which are retained fetal membranes, metritis, ketosis, dampness. All of these can develop COD more than 1.4 to 2.9 times. And the last one is hypothalamic unresponsiveness. A research said that ACTH and cortisol may have an effect on hypothalamus, and leading to the circulating progesterone concentration can be abnormal. So, here is the pathogenesis of COD. When the LF secretion was abnormal, not only the hypothalamus, but also anterior pituitary and also the follicle, such as no production, no secretion, or no receptor. All this can lead into the ovarian failure, and then can be the ovarian cyst. So, what about the treatment? The manual rupture is not recommended because it can lead into the ovarian trauma and hemorrhage, and then can be the ovarian bursal adhesion. So, and we recommend the hormonal treatment instead. The treatment protocol one using the GnRH or SCG with PGF2 alpha at day 0, and then repeat the PGF2 alpha in day 9. The result of this, the is the cow can return to the normal cycle in 72 to 85% within 19 to 23 days. And the pregnancy rate was around 46 to 58%. The second one, you're saying the GnRH and PCF2 alpha 2, and it had a fixed time AI around 16 hours after the last treatment. The pregnancy rate is around 27%. And the third one is almost the same with the second protocol, but it's adding the CIDR or the progesterone with its intravaginal implant. So the cyst will regression within 5 days after the implant insertion, and the ovulation will appear within 7 days after implant withdrawal. So what we can do is to reduce the incidence of the cystic ovarian disease, such as avoiding a genetic predisposition or reducing the postpartum disease and stress, and also do the body condition score monitoring. These are our reference, and here is all of our presentation today. Thank you.